Hi, I'm Stan Kornman. I'm an endocrinologist, and I practice at Ronald Reagan Medical Center.
And I'm Shira Grock, and I'm also an endocrinologist, and I practice in the UCLA Santa Monica Center. So we are going to be talking about gender health today, and specifically talking about gender-affirming hormone therapy. I'm going to start by just going through some definitions so that hopefully we can all be on the same page. And then Dr. Korman's going to go on to talk about feminizing hormone therapy. And then I'll be back to talk about masculinizing hormone therapy. All right. So again, so going through some of these definitions, when we're talking about gender identity or experience gender, that's one's internal sense of their gender identity. Whereas gender expression is going to be the external manifestations of your gender. So the pronouns that you prefer to be used, how, the name that you choose, the clothing that you're wearing. Gender dysphoria is a term to describe the distress that one experiences when their gender identity and their designated gender at birth don't match up. And this replaced what used to be called gender identity disorder. Now we refer to that as gender dysphoria. And usually that's diagnosed after about 6 months of feeling that, again, your gender identity and your gender that was assigned at birth don't match up. So we're talking about transgender patients. These are people whose gender identity differs from the sex designated at birth, whereas cisgender is going to refer to those that are not transgender. A transgender male are individuals that were assigned female at birth, but identify as men, whereas transgender females are those that are assigned male at birth and identify as females. And lastly, gender non-binary are individuals that don't fit into this binary gender narrative, and other terms for that could be gender queer or gender non-conforming. All right, so now Dr. Korman's going to talk about feminizing hormone therapy.
So feminizing hormone therapy is used to attain a desired level of femininity. And at the same time, minimize masculinity. And our goal is to achieve and maintain hormone levels that are adequate to reach those goals. For the administration of estrogens, we're trying to achieve a serum estradiol generally in the range of 100 to 300 picograms per ml. And because so many of the trans females are large, it sometimes takes a lot of estrogen to get to the right place. Oh, went the wrong way. So these are the goals. These are the effects of hormone administration, of estrogen administration. You definitely see a redistribution of body fat and a decrease of muscle mass and strength, and the patients really want that. Softening of the skin, decreased oiliness, a decreased sexual desire, not necessarily elimination of sexual desire, and in some cases there's an increase of sexual desire. Decrease in spontaneous erections is very common, and sexual dysfunction, that is an inability to achieve a normal erection, is also very common. You get a significant amount of breast growth, but not a great amount of breast growth. And most of the patients will find that in order to achieve the level of breast size that they want, they have to get supplemented with implants. There's a decrease of testicular volume, and that's variable from person to person, and you get a decrease of sperm production. The sperm production decrease, according to the Europeans at least, is reversible if you want to produce enough sperm to father a child, and in which case you have to stop the hormone management. And then terminal hair growth is decreased, and scalp hair is not really preserved, and certainly not improved, but doesn't continue to be lost. And the changes in voice do not occur so that achieving a female voice requires a different process. So what hormones do we use? We use oral estradiol. I tend to use mainly oral estradiol because you can adjust it to suit the individual patient's need very simply. And we use up to 6 milligrams a day. That's been demonstrated to be safe in the European studies. And I like to use the estrogens twice a day because estradiol is a short-acting hormone and it works better if you give it twice a day. You can also give an estradiol patch, in which case the estradiol is leaking into the systemic circulation more or less continuously. You can give intramuscular estradiol valerate or cypionate. Cypionate was in short supply recently. I don't know if it's fully replaced. And you give it every 1 to 2 weeks. I usually give these hormones weekly because I don't want there to be very high levels followed by low levels. I would much rather there be somewhat elevated levels followed by somewhat lower levels. And we do not use the sublingual estrogens. We also try to have anti-androgenic therapy. The idea is to interfere with the effects of testosterone. So spironolactone is given almost universally in doses of 1 to 200 milligrams a day. I prefer not to go to 200, but to go to 100, because spironolactone, in addition to being a weak anti-testosterone, is also an antihypertensive, and for certain patients the blood pressure will go down, and they will have lightheadedness and not feel so great. And also the serum potassium rises, and that can be troublesome, although not very often in young people. So I try to keep the spironolactone down to 100 milligrams a day. It's really only very effective when the testosterone level itself has been brought down, because it's a weak inhibitor. We do not use cyproterone acetate in the United States, but we do sometimes use flutamide. We do not use GnRH antagonists or agonists because they're expensive, even compared to the other drugs we use. Medroxyprogesterone acetate is a progestin that is anti-androgenic. I don't use that because it tends to increase body weight with increased fat. I tend to use micronized progesterone, and I use it specifically to inhibit androgen production by the testes, because it has a direct testicular effect. Finally, we use finasteride or dutasteride, which are 5-alpha reductase inhibitors. Their function is to reduce the effects of testosterone on sexual tissues, and they operate directly at the level of the sexual tissues. And they are effective in reducing, for example, hair loss and to reduce testicular size and penile size. Now, what do we worry about? Well, estrogens cause thromboembolic disorders, that is venous clots mainly, and they cause it in high doses. But the experience with transsexuals has been that it does not do that at levels of 6 milligrams per day or below. There's sometimes an estrogen-induced elevated prolactin, probably too much worry about a very minor effect. There are occasional people who are very sensitive to estrogens and get high serum triglycerides, which are not great for your heart, but the frequency of significant hypertriglyceridemia is very low. However, we like to measure the serum lipids, the cholesterol and triglycerides, in all our patients. The increase of insulin resistance may be associated with the obesity that sometimes happens in these patients. They tend to gain weight, and I try to encourage them not to get obese, but some do. Question about whether an increase the rate of gallbladder disease is not really settled. An increase in breast cancer, we blame estrogens to increase breast cancer in postmenopausal women. That question arises in these cases, but the evidence seems to be that breast cancer in transgender men is no higher than breast cancer in cis males. And finally, cardiovascular disease. The way I think of that is cardiovascular disease is the leading cause of morbidity and mortality in the population as a whole. And we should worry about cardiovascular disease in everyone. And you don't get away for free if you're a transgender on therapy. You still have the same risk as everyone else for every other disease. And so how do we monitor patients? I usually see them every 3 months until we get them settled, and then see them every 6 to 12 months. We measure estradiol and testosterone to make sure the estradiol gets into the normal range. Because many of these patients are large, it takes really a significant dose to get there. And we will monitor the electrolytes to check the potassium, particularly if they're on spironolactone. We do cancer screening. Both estrogens and androgens improve bone density, so we don't really think there's a likelihood of diminished bone density. In fact, generally improvement over what they would otherwise be, but we like to manage to look at bone density at the appropriate time. And finally, we'll get a prolactin occasionally to make sure it's not going up. And now Shira will tell us about male masculinizing hormones.
All right, so similar to the feminizing hormones, some of our goals are going to be to attain the desired level of masculinity, and then to minimize any, feminine characteristics that the patient desires to minimize, and also to eliminate menstrual cycles in most cases. In order to do this, we want to make sure we're attaining adequate hormone levels, so we are going to be also monitoring those hormone levels, and make sure, we're checking on things like the bones. Generally, to achieve these changes, we want a serum testosterone level in the normal male range. Different labs are a little bit different, but generally in the 400 to 700 range would be appropriate. So what are the changes that people can expect to experience with masculinizing hormone therapy? So definitely there can be an increase in skin oiliness and acne that generally starts to occur, relatively quickly, about maybe in the first few months of therapy. Facial and body hair growth, that takes a little bit longer, usually starts around 6 months of therapy and is maximal at 4 to 5 years. Scalp hair loss can occur with the testosterone, and that also starts to occur maybe around 6 months. For each patient, it's going to be a little bit different, the exact effects that they have and the time that these effects occur. Increased muscle mass and strength can occur. It does take a few months for that to start to change. Importantly, just the testosterone alone is often not enough, and really we encourage our transgender men to also be, exercising and lifting weights if they want to attain a certain body habitus. Fat redistribution does occur in the cessation of menses, and generally occurs hopefully by 6 months. For some people that's quicker, and for some people that can take a little bit longer. Clitoral enlargement can start in the first few months and is generally maximal at 1 to 2 years. Sometimes that can become an issue for people if they're having sensitivity in that area. then sometimes that has to be addressed. Vaginal atrophy would be another change, as well as deepening of the voice. So for transgender men, we are going to see some voice changes opposed to, as we mentioned, with the transgender women. And the red arrows are to signify the changes that are more permanent and that won't go away even if you do stop the therapy, though those are changes that should be permanent. So how do we do this? What types of testosterone do we use? And so most commonly, we're either using intramuscular testosterone, and that's given every 1 to 2 weeks. And similarly to Dr. Korman, I usually would recommend once a week, so we're not getting as many high testosterone levels and then low testosterone levels. And the dose is going to vary depending on the person. So the dose for all of this is going to vary depending on one's body weight. And so we try to take that into account when starting hormone therapy. The transdermal transdermal gels, there's multiple different formulations of this, but that's also commonly used, and those are used on a daily basis. And, may result in some, a little bit more steady levels, but, depending on the person, people sometimes do better either with the injections or the transdermal gels. There's also patches. The issue with these is that a lot of patients can have skin irritation from the patches. So I'd say those are a little less commonly used, but definitely still an option. In terms of the longer lasting testosterone, so there is an injectable testosterone that lasts a few months, as well as testosterone pellets that are inserted under the skin. We don't use these as commonly, and one of the main reason would be that it's harder to adjust, because once you've given that dose, it's not easy to then adjust the dose. And they do require some special monitoring to do the injections and special services to do the implants. So what are the things that we're monitoring in transgender men? One of the main things that we're monitoring is the red blood cell counts. And so the testosterone is a normal effect of testosterone to stimulate the production of red blood cells. And so we generally do see an increase in red blood cells. One of the things that we want to watch for is that we don't want the levels to go too high. And I'll show you a slide on this, but in general, if you when starting testosterone, we expect the levels to go into the normal male range, but we do want to monitor to make sure they're not going over the normal male range, which could potentially put people at risk for blood clots. The liver dysfunction, there's a lot of recommendations out there to monitor liver function, but to be honest, these are really, the liver dysfunction really only occurred in older derivatives of testosterone, not the testosterone that we're using today. So this is really not an active concern of ours. Cardiovascular disease and cerebrovascular disease, so it's strokes and heart attacks. We don't have any evidence to suggest that this is increased in transgender males after starting hormone therapy. In general, as Dr. Korman mentioned, this is a very, common cause of death, and in particularly actually more so in males and females, but across both sexes. And so, I think the theoretical concern would be putting people in a different risk category based on the testosterone therapy. We don't have any long-term studies to suggest that is the case. There was some data that came out recently suggesting that there are some minor changes in the cholesterol numbers, and so an increase in LDL, which is in triglycerides, which are kind of the worst bad cholesterols, and a decrease in some of the good cholesterols. But we don't, that might just be putting people into the normal male physiologic range. For high blood pressure, again, so the therapy can lead to a small increase in blood pressure, generally not a clinical concern. And breast and uterine cancer, there used to be concerns about this, and the more recent data really suggests that we don't really know that there's any increased risk, and it's the risk is probably quite minimal or non-existent. So this is talking about the hemoglobin, or the red blood cell counts.
Push it again.
Sorry about that. Okay, so here the HGB, that's the hemoglobin or red blood cell count. You can see before therapy, this is in the normal, cis female range, and then as you go through therapy, the numbers will go up. But even 15, that's the normal cis male range, and so that's an expected change. That's not concerning as long as we're monitoring. All right. So one issue that definitely comes up is persistent menses, and this can be very bothersome to patients and frustrating. Generally, we expect the menses or the periods to stop within about 6 months of starting testosterone therapy, and what we would consider persistent bleeding is someone who has testosterone levels in the male range consistently and is still bleeding at about 6 to 12 months out. So the first thing that we want to consider is just general things that can cause bleeding. So just like in cis females, they can have fibroids, and these are benign tumors in the uterus that can cause bleeding. We always want to think about these general conditions that can lead to bleeding. The other thing to start to think about is the dosing of testosterone. And so if the testosterone is dosed every 2 weeks, maybe, and it's an injection, sometimes moving that to every 1 week to get more stable levels could be helpful. And again, just making sure that the testosterone levels are in the desired ranges. Aromatase inhibitors are a medication that can decrease estrogen, and these have been shown to be helpful in stopping periods. One of the issues that comes up is that these are also used in conditions like breast cancer, and with long-term use, we do worry a little bit about the bones. And so generally, we try to use that for 6 months to a year until things are optimized so that we could then stop that medication. Progesterone is another option to sometimes help with decreased bleeding. Some people feel that weight loss can be helpful, so testosterone is converted to estrogen in fat tissues, and so the idea would be that if someone does have excess weight, sometimes losing some weight can help decrease the estrogen levels. And then lastly, if these methods aren't working, then either endometrial ablation or hysterectomy would really be more definitive therapy if the other medications are not working. And sometimes a hysterectomy is part of a patient's plan regardless of this as well. So monitoring is, in terms of frequency of monitoring, is going to be very similar in our transgender male population. So we want to see patients every few months, usually the first year of therapy or until things are stable, and then once or twice a year after that. And at those visits, we would be, checking on the desired changes, looking at hormone levels, making sure everything is steady and that we don't, see any adverse reactions. Particularly for transgender males, we want to be measuring their hemoglobin, again, every 3 months in the beginning, and then once or twice a year. And after, if we change a dose, we definitely, want to then follow up and see how their hemoglobin levels are doing. We're also monitoring blood pressure, weight, cholesterol, just general markers of health. And then a standard kind of cancer screening for whatever tissues are present. And so if you do have a uterus present, then we would want to be, doing pap smears as generally recommended. Same with mammograms, and it just depends on what tissues we need to look at. And then the bone density, as appropriate based on the patient. This is, always something that's kind of in the back of our minds since the sex hormones can affect the bone. All right, so we've talked a little bit about some of the risks with hormone therapy, and we also just want to make sure we talk about all the benefits. And so beyond the desired physical changes, and obviously that's a large part of what patients are seeking when we start hormone therapy, there is from our experience a dramatic improvement in just general well-being. Unfortunately, there's not tons of data that we can quote for this, but people are starting to look at this more. And, some studies have shown, a significant decrease in anxiety. So one study showed about a 30% decrease in anxiety scores, improvement in depression, and just improvement in general well-being. And I think this is really important in our transgender population because in general, there is a higher rate of depression and anxiety. And so this is a really important outcome that we need to remember, that people do better on hormone therapy.
And a lot of my patients have stopped taking a lot of their antidepressive meds because they don't need them anymore, and they're doing well.
Yeah. And kind of along with that, oftentimes, we do encourage patients to, especially when they're starting therapy, to be actively seeing their psychiatrist, just to be able to talk through all the changes that they're going through. So in conclusion, the physical changes that you should expect with hormone therapy, they are variable person to person, and the changes will take different amounts of time to develop, so that some of the changes could start in a month, but some can take up to a year to become evident. The emotional changes with starting hormone therapy are extremely favorable. And while we don't have great long-term data on the risks of hormone therapy in transgender patients, probably a lot of the risks that have been identified are a bit overplayed. And so, this is we're over the next decade, we're going to be getting more and more information on exactly what the risks are. Hormone therapy should be monitored every 3 months when we're first starting for about the first year or so, or until things are stable, and then should be monitored once or twice a year after that. And any concerns such as persistent menses, these things should really be addressed with someone who has experience and taking care of patients in taking care of gender health. All right, so do we have any questions from the internet? Okay, let's see here. Okay. So the first question is, maybe Dr. Kornman can answer this question. So what is the role of progesterone for mood, sexual desire, and/or breast development?
Well, that's a good question. The progestins generally have been shown to depress mood. Progesterone itself, the one that I tend to use, is not very strong at depressing mood, so I think it's favorable. As I mentioned, progesterone directly affects testicular testosterone secretion to inhibit it, so that if someone has a persistent high testosterone level after starting on estrogen therapy, I always put them on progesterone. Furthermore, the evidence is weak to non-existent that progesterone really improves breast development. There are a few people who feel that once they went on the progesterone, their breast development proceeded further, but we usually put them on it within the first 6 months, and they're still having breast development from the estrogens at that time. So it's hard to determine whether the progesterone really stimulates breast development.
All right. So the next question here is, what should I do if I'm a transgender female around the age of menopause? And I presume this is getting at, what should we, given that cis females have a decrease in estrogen at the time of menopause, what should we be doing with estrogen replacement? And this ultimately is going to really depend on the patient. And so if you are someone that has had your testes removed, it's going to be very different, because your testosterone levels will be very low if we stop the estrogen. And in those cases, there's no right or wrong answer, but it would be reasonable to consider at least decreasing the estrogen amount, since that would mimic essentially a natural menopause. Now, for patients that still retain their testes, it's a little bit more difficult, because if we stop the estrogen altogether, their testosterone levels will go up. But it still could be reasonable to adjust the doses and maybe use a slightly lower dose at that point in life. I don't know if you have any other recommendations, Dr. Kornman.
Well, one of the questions is, will you get symptomatic? A woman who goes through the menopause becomes very symptomatic, has hot flashes, etc. And that's not the usual finding with the transgenders. And in addition, so if they don't have symptoms, the motivation to use hormones is less. And my inclination is to stop them and see what happens. By that time, the testes are usually gone, pretty much, in terms of being secretory organs, because they've been suppressed for 20, 30, 40 years.
All right. So the next question here is, what % of transgender men have persistent periods? So there is some data, I think, out of, it was a Dutch study that showed at about 6 months, about 85% have stopped having periods. So that still leaves about 15% that are having persistent periods, and then we need to start to address some of the issues that we talked about. Okay, let's see. So what are the effects of hormone therapy on bone strength in either transgender males or transgender females? So we actually were hoping maybe this question would come up, and we do have some information on this. And as I think as we both alluded to, we don't have great long-term data, but this is something that we are trying to look at. So this was a study that was published last year in one of the endocrine journals, where they were looking at patients over a period of 2 years, and both at transgender men and transgender women. And what they found in transgender men this is 2 years after starting hormone therapy, there was no change in bone density. So that's measured on a DEXA, or a bone density machine. In transgender females, actually one of the studies showed maybe there was a benefit, but ultimately when they compared that back to cis men, there really wasn't a significant change. So what we have so far is very short-term data. So, 2 years is not a lot of time to get bone changes, but at least at that point, there doesn't seem to be negative effects. That being said, this is bone density. These are not looking at fractures or breaking bones. They did try to look at that, but there was only one fracture over the period of a year that they were looking. And so it's not fracture data, but it is bone density is thought to be a surrogate for fractures.
And what goes on is that the transgender females are getting high doses of estrogens. Estrogens are good for bone. They inhibit bone resorption. So they should be in better shape, and their bone density should not go down with the years as it does in cis women. In the males, the transgender males, they have testosterone tends to increase bone density, and they're getting testosterone levels that are actually higher than the comparable levels in cis males as they get older. So in both cases, bone should be protected, and I don't worry too much about it because physiologically speaking, they're in good bone shape.
Should be in good shape, yeah. Okay, so what can you do for gender non-binary patients? So for example, if I want some masculine characteristics but not others, is that possible? What can we do in those scenarios?
So I have a couple of patients like that, and I don't mind giving them low doses of testosterone, and it really makes a huge difference in their lives. I don't try to achieve any particular numerical goal. I try to achieve a psychosocial goal. I feel good when I'm treated. I behave comfortably. My life is improved. I think that you have to understand that achieving a particular numerical value in a blood test is not a proper medical goal. It's helping the patient feel well.
And I think the one other aspect is that, unfortunately, different people do have different responses, and so it's hard to kind of pick and choose which characteristics you would like to develop. So that part is a little bit difficult, but we can adjust our dosing and adjust our regimens to try to achieve different results. Okay, and then can you please discuss persistent pelvic pain in transgender men? So this is another big topic that can be difficult, and actually it was another thing that we were hoping we'd be able to discuss, but we weren't sure if we'd have time. Let me see here. Okay, so similar to the persistent menses, we always want to make sure that we're looking at other reasons for pelvic pain. So such things as endometriosis. There are lots of reasons for pelvic pain that we need to make sure we're just addressing the typical the typical symptoms that can happen in cis females as well. But there are particular things that can make transgender men more susceptible to pelvic pain. And so the use of testosterone is going to lead to some vaginal atrophy, and what that can result in is vaginitis or like inflammation of the cervix, and that can cause pain. Vaginal atrophy itself can cause discomfort. And so, actually sometimes in those cases where even you can use actually local vaginal estrogen to help with those symptoms, and it's just a local effect so it doesn't get absorbed systemically to affect your estrogen levels. There's other people also postulate that some of the change in weight distribution and change in muscle mass might lead to kind of slight changes that could predispose to pelvic pain. anyone who's had surgeries, like sex reassignment surgeries, that is definitely, you always want to think about, could there be any complications associated with that could be leading to pelvic pain. And the emotional aspects are definitely very real. It can be really, tough to get the pelvic exams that are recommended if you still have those organs, and it can be painful as well. And so all of that leads to emotional aspects to the pain. And, some people do report cyclical symptoms, and maybe, things are different at different times in their injectable testosterone regimen. So for some of those people, you could consider transdermal estrogen or transdermal testosterone, or something that will lead to a little bit more stable levels. Sometimes these are things we have to try and see if they're helpful, and if that doesn't work, try something else.
These are in patients who have not had surgery. However, these are not common problems. They're relatively uncommon.
Do we have any other questions that have come in? All right. Well, thank you so much for joining us today.